Okay. So we talk about the respiration in the cellular level. So basically that um, the whole purpose is to provide cells with the oxygen and to help cells to remove the CO2. So that's the whole purpose. And so we have the circulation. This blood carry oxygen and CO2. And so from there, we need to know that what's best. So we need to know that what's the mechanism that our blood carrying these gases, the O2 and the CO2. Um, and so that's the point. For the O2, oxygen carried by the hemoglobin, 98%, and for the CO2, it's a little bit trickier because CO2 is converted to be the bicarbonate, and then traveled in the blood to the lung, and then convert back to the CO2, and then got released out. So CO2, you need to know two things: chloride shift and the enzyme, which is the carbonic anhydrase. So that's the cellular level. Then we talk about bring to the lung, the ventilation. So in the lung, we learned that lung capacity has several measures that we can measure. Basically, that we use the spirometer to measure the spirometry, and basically the major components that we are really interested is the vital capacity. So that is about like 500 milliliter, 0.5 liter. And then another measure is the um, slow vital capacity or just vital capacity. So that's the largest amount the air that we can use in the lung. So the one is that during the normal breathing, the resting breathing, the amount that you breathe in and out. And the other one is the largest one that you can use. So during the uh, exercising or when the time that you need more of this air, you can use those uh, the uh, the vital capacity. So these two basically is a major components.
It's really important.
Yes. So and then lead to, so we can use spirometer to measure that. We can also measure just force for it, blow it out. We can measure the FVC, forced vital capacity. So this basically is the largest vital capacity that we can measure. And also the FEV1, that the amount got blown out in 1 second. Even though we have many different kind of quantity that we can get by asking the patient or person to conduct this maneuver, two clinical relevant measures are these two, FVC and FEV1. That's because that lung disease has two types. So let's look at this chart. We have this chart before, maybe not. So this one is a little bit new, not new. This one is different. This one is the earlier I show you the top 10 cause of death in the America, and if you remember those, the major three disease are cancer, stroke in the brain, the heart disease in the heart. So cardiovascular disease play an important role to cause death in America. Stroke and heart disease are cardiovascular disease. And underneath that is the underneath cause is the atherosclerosis. Yeah, so that's the artery thickening. And so it's the artery wall disease. So that's the major cause in America. But in the world, you can see that the heart disease, the brain stroke and the heart disease are still the top two. So cardiovascular disease are top two. But following that, we have this lung disease. We have this chronic obstructive pulmonary disease. So this is typical. This is also called COPD. So you probably hear this one very often. So this one is also called let's see here. So this one is also called COPD. So this is very common. That's obstructive. So this is obstructive lung disease. Obstructive lung disease. And then the fourth one is called lower respiratory infection. So lower, here we have a lower respiratory. Why is lower? Because this is the lesion in the, basically that's lower than vocal cord, not above, not in the nose, not in the upper vocal cord area, but it's the lower vocal cord. Basically, those are the trachea, bronchial, and alveoli. So, and they have this infection. So basically, we have the prolonged chronic inflammatory continuous going on. So these are the top two, the major cause, two of these major cause effects in the world. And so we need to know how to quantify, how to classify the if the patient has the lung disease. This could be one of the two types. So it could be either the restricted lung disease or it could be the obstructive lung disease. So basically this is the when we want to identify this lung disease, we need to know which one is which. And when we talk about this obstructive, so basically that lung is like here is the lung, right? And then here is the capacity. So here is the capacity. And the larger capacity is called forced vital capacity, FVC. And when we blow it, this is the airway. So here is the trachea, bronchial, the air going out or in. So going this direction. And the speed that it can go in or out can be quantified as the FEV1, sorry, FEV1. So FEV1. FEV1. And so the if the airway is blocked, then this disease is called an obstructive lung disease. And so that even though lung, we still retain the same large of the lung capacity, the speed to let the air to go in and out is reduced. So to quantify it, to detect it, we will see a reduced FEV1 from this patient. But we probably will see the FVC remain the same when the patient has the obstructive lung disease. A typical obstructive lung disease is like emphysema, for example, or asthma is also a type of the obstructive lung disease. And with this air going in, the alveoli is the same, it's not affected, but the airway is affected. So why the airway is affected? Two reasons. One is that here we have for example, if this emphysema, this patient will have a lot of mucus. So their endothelium cells will produce a lot of mucus. So mucus accumulate in the airway, and the airway become narrowing. So the air is difficult to blow in and out. So when the person will try to forcefully blow the air out, air will eventually going out, but it's very difficult. So your FEV1 will be low. FEV1 will be low. So that's emphysema. Another one is the asthma. So this is the due to the allergent. And that is because that here in the bronchi or trachea, we have this smooth muscle. And this smooth muscle form, basically form this muscle to control the diameter. It's very much like the blood vessel form to control the diameter of this airway. And they are super sensitive in this patient. So when there is allergen, then it will cause this muscle to contract to make this airway become smaller. And then it will be very difficult to breathe in and out. So you will also see the FEV1 decrease. So that's obstructive. And as for the restrictive is not about this airway. Restricted is the lung itself. And restrictive lung disease is less common compared to the obstructive lung disease. So restrictive usually happens to the patient, for example, the muscle weakness, it cannot expand, or it could be because of the diabetes, that the material, fat or muscle built up in the chest or around the chest, and that make the lung very difficult to expand. So that's restricted. So this the airway to flow in and out is not affected, but the lung capacity, the way that we can expand it is restricted. It is restrained. And so with the restrictive lung disease, we will see this FVC decrease. Any questions? So that's this how we tell the difference between the restrictive versus the obstructive lung disease. We basically have this patient to blow through the spirometer very forcefully. And then we can get these two measures, FVC and FEV1. FEV1 detect the airway, how fast the airway flows through how fast the air flows through the airway. And that is a sign for the obstructive lung disease here, obstructive lung disease. So for the patient with FEV1 for the obstructive lung disease, you would probably see something like this. So the FEV1 will be low, but eventually it will reach the normal FVC. And for the patient whose chest is restrained, we will have a lower FVC, and that will indicate the patient has the restrictive pulmonary disease, meaning that even though the airway is very smooth, so it can blow out very quickly, but the maxima is lower. It cannot reach to the full capacity of the lung. Any questions? All right then. So here is the pulmonary function FVC, basically the FVC and the F. So it should be, let me see. So this should be FEV1, right? FEV1. So please make correction here. So this should be FEV1. So FVC smaller than the predict FVC is a restricted lung disease. Alveolar surface area is diminished is one of the cause, or there would be scar tissue due to the pneumonia and fibrosis. Pneumonia also can cause sorry. Yeah. So pneumonia and fibrosis in that alveolar area. And FEV1, if it's lower, if it's lower than 80% of the FVC, actually FVC. So if FEV1, so basically that if it's during the first second, if it doesn't reach to the 80% of this maxima, then this consider that FEV1 is low. And then that is called the obstructive lung disease. The airway is obstructed or constricted. The common disease is the emphysema. Commonly, we can see this one in patient with the chronic smoking. Asthma, so this one is the due to the allergy. This is the bronchitis, the infection, inflammation, and so that's this two type of the pulmonary disease. So obstructive lung disease is very common. It's also chronic obstructive lung disease is also called COPD, and that is usually related to the emphysema due to the chronic smoking patients. And this obstructive airway narrowing can be caused by one of these two mechanisms. One is the smooth muscle, very sensitive, so make it narrowing, or the accumulation of mucus, make the airway narrowing. As for the restricted, is the chest wall become stiffed, and so lung cannot expand. And here is some example of this obstructive, like COPD and asthma versus restrictive. Could be the obesity or the scoliosis, that the spinal cord is curved, or the muscle disease, that because when we expand our lung, we need to use the muscle. If the neuromuscular is injured, then we cannot expand it. Or interstitial lung disease, that is between the lung and the chest wall, interstitial fluid. So that is the disease. And here we basically link the disease to these two measures, FVC and FEV1. So these two measures, if FVC is low, is the restrictive lung disease. If FEV1 is low, is obstructive lung disease. And then let's move on to the next. The next topic is how do we regulate our ventilation? So basically, ventilation is controlled by our brainstem. As we mentioned before, that our breath is a is a pattern of a muscle movement. So that pattern is controllable, that we can stop our breath if we want to. So this muscle is part of this voluntary skeletal muscle. So it's not smooth muscle or cardiac muscle that we cannot control. This muscle is the muscle that we can control. Those are the skeletal muscle. But we don't have to, if we want to control it, we can control it. But if we don't, then our brainstem will take it over. It generate a pattern. So we will continue breathe, even though we are during sleep or during any time, we keep breathing. This part of the nervous system is the respiratory center in our brainstem. They are in the medulla oblongata region as well as in the pons area. So there is a network to control our breath pattern. This network receives several input to control it. Our body has a lot of this kind of design that's it form an isolated pattern generation and to control our body movement, while this pattern generation can also be adjusted by the sensory input. For example, that our breathing can be adjusted by our mental, the intention, or like a walking. Walking is also a pattern generated movement, can be controlled by our intention to make it faster or slower. With this ventilation movement, this pattern generation can be affected by the CO2 level in our body. So it linked with the chemoreceptor. So basically that's the way to trigger us to breathe more is by our O2 and the CO2 level in our blood. So if our CO2 level is high, we will breathe more because we want to exhale those CO2. And CO2 level high is related to the acidic level. So if our body has higher acidic level, it will also trigger us to breathe faster, larger. So that's one. And the other one is O2. So if our O2 level is low, we will also breathe harder and faster. So let's look at this. So here our ventilation receive, the major one is the chemoreceptor. Baroreceptor is related to the sympathetic nerve. When baroreceptor detect our blood level is low, sympathetic will be triggered, and the sympathetic can also cause our breathing become higher. Stretch receptor is that when we stretch our lung to a certain level, we cannot stretch it further. So there is a protection to prevent us to stretch it too much. Irritation and the chemical stimulus to affect not just the lung, but the airway, the respiratory airway, and also other sensors like pain, temperature, and abnormal visual sensations. This can also affect our not just the breathing, but the airway response. Among all these, the major one is the chemoreceptor to control our, to affect our the respiratory center in our brainstem. Let me check on this one very quickly. So there are two chemicals that affects our ventilation, and these two chemicals can be detected by the chemoreceptor. These two chemicals are CO2 and O2. So our body has two type of chemoreceptor. One is in the central, that directly related to the medulla, and this region detect our CO2. So when CO2 level is high, it will cause the pH level high, and then pH level high, acidic level high, will then trigger our brain directly affect our ventilation to breathe it harder and faster. So that's the central. Peripheral is located in the chaotic body and aortic artery. And this one detects the O2. So when our blood, when this artery blood has low O2, then it will, the major is the O2, but CO2 also can trigger it to send signal to our brain to increase the ventilation. So look at this one here. So this is the medulla and the pons is where we have this respiratory pattern generator, and it's overall is triggered by CO2 and O2 pH. CO2 directly affects our central chemoreceptor. O2 and the pH affects our peripheral chemoreceptor. Also, we can be affected by the emotion, sympathetic nerve, and also by our intention, that higher brain centers or limbic system. And this is about our emotional control. And then it can also affect our breathing pattern. So this one summarizes, kind of give you a broader view of our ventilation. It provides the mechanism to control our, to breathe in oxygen, breathe out CO2. This system can also filter, especially the reason that it has long travel from our nose into our alveoli is because that we need to warm it to humidify the air. So no matter what kind of condition we are in, situation we are in, we can always have the same quality of the air reach to our alveoli. It can also filter not just the nose, but also along this airway that if there is particle, it will be wrapped by the mucus, and then we can remove it. And also protect us from the outside. This protection are involved in the by the mucus. So if there's any like virus or bacteria, they will have to go through this mucus in order to enter our body. This also plays an important role in speech because we need to control our breath, our air, and use it to make speech, and control our pH level. Our body control pH level at in two organs. One is in the lung, the other one is the kidney. So